The outline of the slides are definition of oligometastasis and traditional treatment procedure with brain mets with evidence, and also definition of the SRS SRT treatment flow chart of and our study. So it is an old paper, Journal of Clinical Oncology, 1995. Hellman state that the oligometastasis disease, this suggests that there are tumor states intermediate between purely localized lesion and those widely metastatic. An attractive consequence of this presence of a clinically significant oligometastatic stage is that some patients so affected should be amenable to curative therapeutic strategies. So if it is localized, cure with local treatment possible, but in case of oligometastasis, cure with local treatment also possible. But when it is systemic treatment, local treatment for symptom control also needed. So in case of definition of the number, the image detected oligometastasis is 3 to 5, but number of metastases also surrogate the marker of the metastatic capability as well. In this non-small cell lung cancer study, systemic review of the oligometastatic state that finds that the number of mainly brain lesion, primary site is brain, and the number of lesion also higher in single, strongly based on the solitary brain mets. So brain mets occurs 20 to 40% of adult cancer, and incidence is newly diagnosed brain mets 3 to 10 times the incidence of newly diagnosed brain mets tumor, and number of diagnoses of brain mets increase, and it is highly in lung cancer. We all know that 40 to 50%. Later on, breast and melanoma and colorectal. And these the primary sites of histology subtypes also roles the therapeutic management of brain mets. Brain mets have the poor prognosis and overall survival 6 to 9 months after diagnosis. So how could we proceed the brain mets patient for the SRS or FSRT? Definitely it is the role of multidisciplinary tumor board, and where we differentiate the communication and discussion with the patient for the overall survival prognosis of progression of the survival quality of life. And definitely cost is a matter for treatment, the higher technology, and the breathing of the treatment and delayed the systemic treatment initiation, other immunomodulation, because the versatility of the brain mets occurs in all aspects of the disease, primary. And the traditional treatment procedure of brain mets is definitely in case of single lesion surgery, whole brain radiation, SRS, and chemoimmunotherapy also the part. And this shows the guideline that brain mets, how could we treat? If it is single mets, no systemic disease, surgery can possible, and there is systemic disease, surgery or whole brain RT can be given. And in case of brain mets, 1 to 3, and it is less than 3 centimeter, and if it is radiosensitive, so whole brain radiation or SRS is also possible. And post SRS recurrence, no systemic disease we can follow up, and if it is systemic disease, whole brain radiation is the option. And the changes occurs because diagnosis of much more brain mets and much more asymptomatic brain mets as well, because the vast improvement of the cancer treatment, and treatment is much more brain mets with SRS now, and use of systemic therapy as well. And we also find that improved outcomes of brain mets patients in last decades, because the cumulative survival is more than 20 months in last decades, 2010 to 2022, in case of brain mets patients. If you find the surgery, we definitely have the options for the biopsy as well as the resection, and it helps the histology, molecular study, and adjuvant therapy, and that also improves the overall survival. So surgery can improve the clinical life-threatening situation, and due to analysis of the histology and molecular pathology, treatment can be individualized. So these are the indication of surgery. I'm not going through much of them. And this also, this study also ERTC 22952 shows that the adjuvant radiation, whole brain radiation, also improve the overall survival in case of surgery. But what happened if surgery and cavity-directed SRS or FSRT given? In the right side of the, if we give the fractionated treatment for the SRS or FSRT, like 3 to 5 fraction, So the overall 1-year local control is much higher, which is say in case of single fraction around 80%, but if we give the FSRT, it is around 90%. So post-operative whole brain RT has been the gold standard definitely, and cavity-directed SRS and FSRT provides stable local control within the tumor cavity and may postpone the eliminate of need of the further whole brain RT. So SRS with or without whole brain artery might be appropriate for the tumors with the following features. That is, who are the poor candidates for the surgical resection? Because we all know that brain mets is the occurs in case of elderly patients also who are not amenable for the surgery, and deep or inaccessible location and maximum diameter 20 to 30 millimeter. Radio sensitivity also histological features, and brain met situated close to the challenging area. So what happened to the static surgery alone for the multiple brain mets? A review of clinical and technical issues where the oligometastasis was 1 to 4 in number. And it also shows that excellent local controls with SRS alone 70% after 1 year. Better local control in some group SRS plus whole brain RT, and improvement of distance control in patient treated with combined whole brain RT, where 37 to 70% for SRS alone and 59 to 92% whole brain plus SRS, and no effect on functional independence on overall survival. And if we come the era of SRT or FSRT, SRS, the definition of SRS is that this is a type of external beam radiation therapy that used special equipment to position the patient and precisely give a single large dose of radiation to a tumor. It is used to treat brain tumors and other brain disorders. And FSRT delivers radiation therapy in smaller amounts over several treatment sessions. Both SRS and FSRT deliver similar total dose of radiation. And if we select a brain mets case, definitely we have to think about the number of mets, size, location, necrosis, consistency, with or without edema. Because these all factors, the case selection is the prime factor to understand which is possible SRS or FSRT. And the treatment flow chart, if we see that immobilization is the main first step, and fixation device needed for the immobilization. Imaging technique, MRI plus CT scan, and image registration with MRI and planning simulation CT scan. And we have to target delineation and treatment planning, then data transfer, quality assurance definitely needed, and patient positioning and verification for the treatment delivery during the treatment delivery. So recommended image for brain mets detected need MRI definitely, and follow-up also need the MRI. And MRI, CT scan, radiosurgery planning need to for the delineation of the GTP and organ at risk on MRI, and most of the times we use the T1 contrast, T1 gadolinium contrast. And the planning PTV in case of LINAC, we are doing most of the cases with LINAC base, so it is around 2 centimeter and 80% isodose line. But in case of CyberKnife, there is no margin and 50% isodose line. Regarding the margin, this study shows that 2 millimeter margin is safe, and 2 millimeter margin seems to be significant to cover the microscopic tumor expansion. These are the indication for SRS and FSRT. So single lesion is better SRS, and multiple lesion we can go for the FSRT. And these are the dose recommendation for the tumor size. If it is less than 20 to 24 gray, we can deliver in the SRS, and 15 gray in case of larger tumors. So this is a single fraction versus multi-fraction stereotactic radiotherapy for large brain mets, a comparative analysis of local control and risk of radiation-induced brain necrosis. This is one of the delayed factor, adverse factor, and it found that if we go for the multi-fraction SRS, that is FSRT, the 1 year risk developing radionecrosis is much less than the single fraction. And the organ at constant dose, and we have to definitely prevent the cerebral edema with the steroids. And this is our case, which show the patient setup and MR fusion with the appropriate 2 millimeter margin of the GTV. And this is the dose distribution of the 80% isodose curve. I think this the 80% area, and the dose color wash for the GTV and PTV regions. And in the, our statics, there is 10 patients we treated so far, most of the lung primary, most of the single, and 50% male and 50% female. We treat with 25 gray in 5 fraction, also 27 gray in 3 fraction. But most of the cases, a single case with the cavity directed 5 in 5 fraction, and rest of the case 9 in 9 3 fraction most of the time. And ECOG performance status was most times 2 out of 5. And this is the survival status, the highest number 32 month, that is the primary of thymus, and definitely it's a good prognosis, and other cases still have the similar findings. So in conclusion, that we reveal that better overall survival for all patients include in with linac-based FSRT, and 5 in 5 gray is inferior to 9 in 3 gray, and we can select the case judicially and manage the FSRT without long duration of whole brain RT with less neurocognitive impairment. Special thanks, and thanks for the organization.